Hello, everybody. I'm back. Dr. K. Agarwal, President, Confederation of Medical Association of Asia and Oceania, past National President, Indian Medical Association, and President, Heart Care Foundation of India. And you are watching Med Talks with Dr. K. Agarwal, 7 p.m. show, 112th non-stop edition on COVID-19. Let's have the headlines of the day. Big news in the field of corona vaccine. The BioNTech German company, along with the Pfizer in USA, has announced that their BNT162b2 vaccine, which is messenger RNA given in 2 doses, day 1 and 28 days, produces 90% efficacious in producing cellular and humoral antibodies, and the antibodies were demonstrated 7 days after the second dose. The Pfizer share market has gone up by more than 5.5%, but also carries a bad news. And the bad news is it requires minus 80 degree of temperature, frozen, to be shifted from one place to another. Therefore, that is a challenge. Not a bad news, but a challenge with that. The Biden Care boost for Indian pharma sector with an increased push for generic prescriptions and access to affordable healthcare. Pre-existing antibodies created by the immune system during infection with common cold coronavirus may protect against COVID-19. The fear of second wave looms in Punjab as COVID-19 cases surge. With Diwali on Saturday, November, arrangements have been made for virtual Deepotsav in Ayodhya given the COVID situation. Tata Medical and Diagnostic, the healthcare unit of Tata Group, launched its COVID test kit on Monday, which will be made available at labs and hospitals from December. Let's go to the topic of the day. We're going to have a Singapore experience. Couple of days back, we have Dr. David Barbie, the president of WMA and the past national president of American Medical Association, to talk about the AMA experience and the way America has handled COVID-19. Today we have a special guest, Dr. Chong Ye Wo. He is a senior physician in Singapore Medical Specialist Center with more than 20 years of experience in the private practice of internal medicine and manages a wide spectrum of medical diseases. He is passionate and competent in his practice, often providing much needed relief and advice to the patient and their family members. Widely known for his warm smile, his knowledge and compassion gives his patients the confidence and assurance they need. The smile I can still see. He is the chair of the membership committee. He has been on SMA council members in 1998. He was the SMA president from 2009 to 2012. He is currently chairman of the Ministry of Health SMC CME coordinating committee. He is also the chairman of Confederation of Medical Association of Asia and Oceania, of which the Singapore Medical Association is a member. He is also a member of SMA IDA Ikatan Dakitar Indonesia Joint Committee, which works on an MOU. So I welcome you, Chong, to be here with us. The pattern will be that I'll ask you to give a small presentation, and then we will have a discussion. Then we may invite a couple of people who are joining if they like to ask any question with you. So all my viewers, I present to you Dr. Chong, an eminent internist, specialist, a person par excellent as far as his smile and knowledge is concerned, both together. Chong, all yours.
Thank you, President Agarwal. You're most kind, such a kind introduction. And thank you for letting me talk to your audience. I think it's a huge audience. The numbers are always very big with your shows. I'd just like to update everyone on what's been happening in Singapore. Now, as you know, Singapore is a very small place. We're about 500 square kilometers, and we have about 5 million population. So it's equivalent to perhaps a small city in India, you know. But having said that, we do have some challenges when it comes to COVID, because we are a very, very open economy. We have no hinterland to speak of. So we really, really have to depend on a lot of international trade and commerce, etc. So that has been a huge challenge for us in terms of COVID. I'd like to start with some slides that I've prepared. Perhaps I can have the first couple of slides, please. Thank you. And while the slides are being prepared, yes, thank you. That's my email, so you can always reach me. And next slide, please. All right, this is the dashboard as of today. So this is current as today, and we have in total about 58,000 odd cases. We have a lot of imported cases, 1,285. As I said, we are slowly opening up the economy to the surrounding regions, and therefore we're getting imported cases. But we quarantine everyone that comes in, so we are on top of the situation. They are put into a hotel room for 2 weeks, and if they turn positive, we know exactly where they are and what to do with them. Now we have about only 53 active cases with us, and the majority are all discharged, because we're actually coming to the end of our first wave of COVID infections that started somewhere in January, February this year. You can see we have these in-community facilities. These are facilities that we built to house people, because the majority of the COVID patients we have in Singapore right now are very well. And I'll show you some data later on as to how well they are. Hospitalized, they're all pretty stable, 33. Nobody is in ICU. And unfortunately, we have some patients who have deceased, but 28 of them in total since the beginning of our pandemic here in Singapore. We've done a lot of swabs. We've done 3.8 million swabs, and some of them individual persons, about 1.1 million. So that's about 680,000 per million, and 200,000 per million of unique persons swabbed. And our swab capacity in Singapore right now is about 28,000 swabs daily. We hope to hit about 40,000 swabs. Now, can I have the next slide, please? Now, this is a very interesting data. This goes all the way back to April, when our first 1,500 cases in Singapore. It's a bit busy slide, but if you can see it, look at it. The blue bars are people who need oxygen, and the orange bars are those people who need intensive care. And you can see that it's all broken down by ages, and those below 35, about 3% need oxygen, 0% need ICU in Singapore. So bearing in mind, these are the first 1,500 cases in Singapore, and this was around April. Now, if you look at 60 to 69, the second last two graphs at the back, you can see that if you add up the total, in that age group, 55% need oxygen and 36% need ICU. So early on in the pandemic, we knew without a doubt that we had no choice. We had to lock down the economy because of the dichotomy of the disease. The young, hardly any symptoms, they'll be running around spreading it, and the elderly will be in ICU. Now, at 58,000 cases, in a strange way, because most of our outbreak actually are actually not community cases. We only have about 2,000 odd community cases, but the majority of our outbreak are in our migrant workers. And these migrant workers live in dormitories, and these dormitories are packed. And so there was a huge dormitory outbreak, and something like 56,000 patients came from the dormitories. Now, fortunately, or whatever way we look at it, most of these dormitory migrant workers were young. They were all in their 20s and 30s. They were very fit because they were working long hours every day, blue collar, And therefore, we had very few that went into ICU. Now, it would be very different if we had 56,000 aged people. That would be a very, very different scenario. We only have 1,000 ICU beds in Singapore and perhaps 1,000 state-of-the-art isolation rooms. So if we had 56,000 elderly, you go do the math. We will have 40% of those people in ICU. And our data shows that the average person who perished, meaning the 28 who perished, they actually spent about 25 days in ICU, and they occupied that ICU bed for 25 days. So it would have been a terrible situation if it was 56,000 elderly people. Now that's next slide, please. Now this is just a slide that shows that early on in the disease, this was around April or May, we already knew that the crucial period was the first 5 to 7 days, and that's going to predict how bad the patient's going to turn. So, and most of the action would happen between day 7 and 12. But day 5 to 7, or day 5 and 6 was very, very critical. That's when we can actually arrest the situation before the patient deteriorates. Next slide, please. Now, I just want to show you what's happening now. As we speak, the first wave of the pandemic is coming to an end, or rather it's tapering off. And for the last 2 weeks, we have maybe 0 to 1 to 2 cases a day in the community. Our dormitory migrant worker outbreak has been under control. And so we are facing a decent situation here. But the challenge lies in the fact that we have to open up our economy. Now, these are some of the electronic applications that we have in Singapore. The first is called Safe Entry. It's an app where any business premise owner has a QR code on the wall, and you scan the QR code, and you get this Safe Entry check-in or check-out. And then the next little picture that you see is actually showing you what the possible exposure you have when you use these electronic applications. So it'll tell you for the last few days, where have you been, and were there any COVID cases and so on in the where you went to. Now the next slide, please. Now we also have, you can see, we also have another app, which is what I'm holding up in my hand now. This is actually a token. It's a token issued to every Singaporean. We're in the midst of issuing it now to maybe, out of the 5 million persons, we have maybe distributed about 500,000 to 1 million pieces of this. Everybody carries one of this, and it's using Bluetooth technology, and it'll speak to each other. So you can see from my slide that it'll tell you the past 14 days, how many Bluetooth exchanges I've had. So I've had 1,400 Bluetooth exchanges with fellow token holders. There's both a physical token and there's also an electronic token on my iPhone. So you have a choice of using both, but coming December, when everybody is issued one, the whole 5 million population is issued one of these, this will become mandatory. So these are some of the ways in which we are doing contact tracing. Now, the privacy laws are all respected, but what happens is that if a patient turns positive, he'll be asked to surrender his token, and then the analysis will occur with the data stored on the token. So this token's shelf life is about 6 months. There's a little battery in it that will allow it to last for about 6 months. Now, next page, please. Now, I wanted to show you 2 URLs, which I'll show you shortly. The first is our Ministry of Health website in Singapore. It's called the COVID SITREP, and I'll ask our tech team here to display the website.
Ritu?
And this website is very, very good. It's a Ministry of Health website, and it tells you, for example, this is what it looks like. So you can tell all the statistics that I got just now came from this table. And you can see for yourself, total number of cases, active cases, 0 in ICU, in the general ward. They're all very stable. They are in isolation areas outside of a hospital, being quarantined, but they are not. They are very well, so they're being quarantined outside of the hospital. Discharged from the hospital, completed isolation, and demised patients 28. I'd like to click on the second tab, which is a summary table. And you can see, can you scroll down all the way to the bottom? And this is a fantastic summary table that we have. And it just shows you straight away all the various situations that we have in Singapore. For example, population at risk, 5.38 million and 2,270 community cases. And population at risk of migrant workers, 323,000. 54,000 were migrant workers, and the rest in total will be 58,000 patients, and out of a population at risk of 5.7 million. So this is a fantastic table that is updated on a daily basis by the Ministry of Health. Now, I also like to show you another very interesting website, and that is the other URL that I have on the slide just now, and that is a clinical summary. So what has happened is that we have actually have this clinical summary website where you can go to, and all the data, for example, on anticoagulation treatment, and Ritu will now show you the anticoagulation treatment or the dexamethasone treatment, and this will be a display of all the latest literature search and so on that our research teams have actually put up as a guide to doctors. So we have, should anticoagulants be used for venous thrombosis, prophylaxis in COVID, etc. And Ritu, can you show the other on the dexamethasone? So you can actually access these websites and look at the clinical evidence that has been put up by our ministry website. Very, very useful. We found all this very useful in daily practice, and I'm sure you'll find it very useful as well. So in summary, really, the challenge right now is opening up our economy. A lot of our economy depends on the seaport. So seaport is not a problem because most of these are container ships and so on. But it's the airport that's been really, really heavily, struck down by this pandemic. So our air traffic, we usually have about 20 million visitors a year to Singapore via the airport, and that has come to a small trickle. It's reduced by more than 95%. So that has really been tough for the economy. And as you know, we are right in the midst of a big hinterland, and the airport is really, really critical to our economy and our commerce. The trade figures of Singapore are about 3 times our GDP. So trade is really, really important to us. And the challenge of opening up the economy, really, as with most other economies, we fear the second wave. And I think most countries are really, really struggling with opening up the economies and not allowing a second wave to come in. So I'll just stop right here, and perhaps President Agawal, he's the president of CMAO, and I'm the chair. So President might want to ask me some questions or have some questions from the floor. Thank you.
Okay, thank you, Dr. Chong, for a wonderful presentation. A country of 5 million population. I live in a city of 19 million.
Yes.
Only, and Delhi is one of the smallest city in the country. It is the capital. And you are having, but I would not say you are a 5 million population. I would say you are a 7 million population, because 2 million are visitors at any given time. 2 million per month, which is 20 million visitors, would mean it will add to around 2 more million people in Singapore at any given time. Still, I want to debate on certain points.
Sure.
Only 28 deaths. Only 28 deaths. Deaths are only 5 per million population, which is extremely low. So
Yes.
I want to come back. See, if it is, let me first compare Hong Kong with USA. And in USA, let me compare Hong Kong with New York. Hong Kong is more densely placed than New York. But New York had very high mortality rate than Hong Kong. So that's an example which comes is density may not be the only reason. Because if density was the reason, say you said that most of people came in a laborers and in a migrant population, which are highly densely populated. In that situation, New York is more densely populated than Hong Kong, but New York mortality, Hong Kong is more densely populated than New York, but the mortality in New York was very high. So let me come back and try to find out what can be the reason, and you can debate over that. One is that from May onwards, we have D614G mutation. And now 99.9% of the virus is D614G mutation. All over the world, after May, the mortality is reducing. Your opinion?
Well, in Singapore, for example, one of the a very important local factor is that firstly we had the experience of SARS.
So I will come back. At the moment I'm talking about it. I'm talking about the whole world. Do you feel that the new mutation is now, because we are seeing a pattern in the complete Europe, number of cases are peaking, but deaths are reducing. So one factor can be D614G mutation. Okay. Second factor I want to talk about it. If you see Singapore, Hong Kong, Korea, China, Taiwan, they are behaving the same way. The only why they are behaving the same way, these are the only countries who have tasted SARS and MERS in the past. So all those countries who have tasted SARS and MERS in the past, they are showing significantly low mortality. Can that be one factor?
I think so, yes.
So they have tasted the SARS. That can be one reason. Yes. Do you also think that these people are more sensitized to wear the mask?
Oh, yes, for sure. Yes.
Do you also feel that they have more preparation in terms of AII rooms than the Europe and USA?
Oh, for sure. Yes.
Now I'm not comparing between India and you. I'm comparing Singapore versus UK, means European countries, and Singapore and Hong Kong versus American countries. American countries have never faced a need of an AII room so much.
Yes.
Can that be one of the reasons?
For sure, yes.
That can be one of the reasons for that. And then what are the protocols of treatment in Singapore? Are they as strict as US FDA or not?
Honestly, we have our ICU care is pretty good. So
no, I'm not talking about. I'm talking about flexibility in treatment, because in USA you have to go absolutely full stop, comma, as per dictated treatment approved by the FDA or something. So in India we have flexibility.
Yes, we have flexibility too. Yes.
So flexibility, and that flexibility is there also in Hong Kong, South Korea, and other countries.
Yes.
Okay. Is there anything which can be related to a particular races in India? Because I'm trying to work on that particular races are behaving differently.
I actually asked my infectious disease colleagues about this question, which you raised in our last webinar on Saturday. And they say that because in Singapore, we have Chinese, Indian, and Malay population, quite substantial. And so far, they have not found any differentials in Singapore.
No, what I'm trying to say, what is common between China, Taiwan, Hong Kong, Singapore, and South Korea? What is common in terms of people?
I think it's basically we have a majority Chinese population here. So a lot of these countries have a diaspora, Chinese diaspora. So that's similar in that way. Our Malay and our Indian population is much smaller.
So do you think that Chinese diaspora is showing some different results in the community?
My colleagues my infectious disease colleagues here say they don't think so. Not in Singapore anyway.
And how are they different from the European and the US? Why European mortality is so high? They have, so let me come back. That the inflammatory diseases, when we come back to inflammatory bowel disease, inflammatory thyroiditis, so SLE, they are much more common in Europe.
Yes.
They are much more common in Europe. If that's so those countries where the incidence of inflammatory bowel disease and inflammatory disorders is high, they probably have shown a very high inflammatory response with COVID-19. What is the incidence of SLE in Singapore? Rheumatoid arthritis, SLE.
It's nowhere near the Western populations. Much lower. Yeah.
So that can also be one of the reasons.
Yes, possible.
That also can be one of the reasons.
And we also noticed that there are less thrombolytic disease in our local population compared to the Westerners.
So that is related to inflammation again.
Yes.
So we are less inflammatory prone. So all those people who are less inflammatory prone, maybe they are being protected naturally because this condition has a viral response, a immunogenic response, and an inflammatory response. And if that inflammatory response is exaggerated, that will be exaggerated only if you have a baseline high inflammation. So all those countries who are baseline high inflammation probably are showing more mortality with that. Now, what are the basically, apart from that, I just want to see your glimpses of SARS versus the COVID-19.
Oh, okay. So
just for a few minutes, stop thinking about COVID, go back to SARS and talk about SARS. Talk about SARS experiences.
Okay, so when SARS first hit Singapore, we were totally unprepared, and we had no idea what we were dealing with.
So what were you doing at that time?
At the time, I was out in private practice. It was 2003, and I've been out in private practice maybe for about 10 years. And we were completely unprepared, both public sector and private sector. And for example, we have never heard of an N95 mask at the time. And so we were all scrambling to get an N95 mask. And even the public sector couldn't get enough N95 masks. So in the end, for the private sector, we were pretty much left on our own because the government just couldn't handle both private and public. So what happened was that I still remember our medical association went to beg, borrow, or steal. And we managed to get 5,000 N95 masks from the government. They somehow managed to get 5,000 masks for us. We were on our knees begging for it. And then we distributed to our GPs. And my God, there was a wave of GPs that showed up at our medical association premises. And I think they were all going to fight each other for the masks. So it was really bad. And we quickly got organized and we started teaching doctors how to wear PPE, how to organize a clinic to handle the SARS virus. And can you imagine, we had sessions of 50 GPs all in full PPE in one room, all sitting next to each other and lecturing them on what to do, because we had to quickly come up with protocols and everything. And it was so frightening. And at the time, several doctors had died and nurses had died. So the fear factor was incredible because, you know, we've never seen anything like this. And doctors and nurses were dying, you know, our colleagues were dying left, right, and center. So it was absolutely frightening. And the doctors who died, obviously, were young. And the nurses who died were young because of the cytokine storm. And we had no idea about this cytokine storm at that point in time. So the fear was incredible. I mean, it's something we still have a bit of post-traumatic stress over thinking about it. So subsequently, stung by this bitter lesson, we have prepared over the years. My goodness, we have an N95 factory in Singapore by 3M. And we are so organized now. We have pandemic clinics. We have a fantastic logistic situation. We built a national infectious disease center, and it was completed last year. It's a state-of-the-art ID facility, and it has 300 special isolation rooms with exchanges of 15 to 18 times per hour. State-of-the-art, can be expanded to 500-600 rooms, can double the capacity if we wanted to. And that, we thought initially might have been a white elephant, but my word, it has paid back in spades. And that NCID building, you can go Google it, it's called NCID, National Center for Infectious Disease. And it has really been the epicenter of our fight against COVID. Almost about 60 to 70 of the sickest patients are handled there. So we have really learned a bitter lesson. And we had dress rehearsal of H1N1. I was the president of the Medical Association when H1N1 hit us. It was nowhere as bad as SARS or COVID. But, it was a good dry run for us because it put into all our systems, our logistics, our distribution of PPE to all the clinics. And as a result of all these lessons learned, for example, each clinic at licensing time must have a stock of PPE, 1 week supply of PPE in every clinic, enough for all the doctors and nurses for a whole week. And then the supply will come from the government warehouses. So we have really learned a lot of bitter lessons. And I think that's what's happened to China, Taiwan, Hong Kong as well, and South Korea as well, because we've all learned a bitter lesson and been burned very badly. So that's a little vignette of our experience through SARS. I hope that was helpful.
We have been able to get a lot from the Singapore, but we need more, but after a short break.
Thank you.
You are watching Med Talks with Dr. K.K. Agarwal. This is special COVID 112th edition, and I have with me Dr. Chong from Singapore, who has been sharing about the Singapore experience. And before going to the break, he has shown us how those countries who have tasted the SARS and the MERS have done better. And he has also said in Singapore, the only catastrophe has been the migrant workers who have been living together in densely populated areas. Otherwise, Singapore would turn out to be an odd man out as far as COVID-19 is concerned. He has said very clearly that their protocols, their preparedness, everybody was aware of the SARS experience, and then they had also had a dry run in 2009 when H1N1 came, and they built up one of the best ID specialist hospital, which they were thinking to be a white elephant, but has now come out to be an handy. And every citizen in Singapore now is carrying a tracker, which, if they become positive, somebody can trace everybody whom they have met in the last 5 to 7 days. Obviously, after Corona, it will be used by all the wives to track the movements of their husband, but that will be after Corona, not before that. With that, so we come back to some more. What about US? What about this vaccine, which has come from Pfizer today, and they said their vaccine is 90% efficacious with BioNTech. It's a messenger RNA vaccine, like a Moderna vaccine, and they say that their vaccine is 90% efficacious, both from humoral and cellular antibodies. There have been two cases where one of the person who broke open his tooth in the night because of the shivering because of the vaccine. But what are how is the reaction in Singapore hearing about a possible vaccine?
I think we will really need a vaccine to open our economy, because we have no hinterland. We are just a small little island, and we really need a vaccine for all 5 million of us to resume business as usual. So that is really I see very critical to us. Having said that, Singapore is no stranger to first mover vaccines. So in 1959, if I'm not mistaken, we vaccinated 200,000 babies in Singapore with the polio vaccine when it first came out. And remember, that vaccine was only 50% effective, but it wiped out polio. And in 1987, Singapore was also the first few countries in the world to institute hepatitis B vaccine at birth for all babies. And we've eliminated most of the hepatitis B carriage, which used to be about 10% of the population, to now to about 1%. So we are not strangers to first movers with vaccines. And we certainly look forward to a vaccine that can allow us to reopen our economy. So that is the thinking, and we welcome good news of vaccines.
So there is
The only problem,
is a California-based company called Arcturus Therapeutics, and Duke and US Medical School in Singapore. They are also working on a mRNA, messenger RNA vaccine, which is a self-replicating design, and that leads to a greater production of virus. And they are in a phase 2 trial in Singapore General Hospital. Do you feel any information about that?
It's too early. We haven't had any information yet, and they're very because there's a private sector entity involved. They're very careful about what they disclose to anyone. So we wait for the news to arrive from that side.
So personally, you have three choices. One choice is a killed vaccine,
yes,
like that of a China. The second is a vector vaccine, which can be the Russian human or the chimpanzee's Oxford. Or you have a messenger RNA vaccine, Moderna and now Pfizer. Which one will you choose if you are given a choice to take, and why?
I think the safest we know is the killed vaccine, the inactivated vaccine. And as I believe, President, you have mentioned before, you can do it more than once if you think that it's not efficacious. So I'm looking at the Chinese vaccines. Honestly, look quite good at this point in time. They are all inactivated vaccines. So well, the jury's still out, but I'm sure our ministry is carefully looking at all possibilities and trying to figure out what is the best way to go. So we are waiting for their guidance.
What about when you're talking about two protocols you mentioned, specifically the steroid protocol, which you mentioned, and anticoagulation protocol? What are the protocols you're using?
Okay. We are using the steroid protocol for sure. As far as the anticoagulant protocol, I spoke to my friends running the ICUs in NCID, and apparently they haven't seen very much thromboembolism, because it could well be that our local population doesn't have those mutations that you usually see in Western populations. For example, Leiden 5, protein C, protein S, prothrombin. I always forget that number. There's a long number, the prothrombin mutation, and so on. So they haven't found the need to give anticoagulant or to use the anticoagulant protocols as much as they like to.
And at what stage they give steroids in Singapore?
They assess usually at day 5 to day 7. And if the patient is clearly taking a turn for the worse, they'll start steroids.
And what about going back to Remdesivir and Favipiravir?
Yes, we have actually not used those at all in Singapore. So it's very interesting, but we have not used that. And although it's FDA approved, we've actually not used those two at all, except in the context of clinical trials.
Okay, so what Dr. Chong is saying, because we have not used, therefore our mortality is the lowest.
Okay. Well, well, I leave everyone to draw their conclusions, but we've not used those two at all.
Just joking. Because why I'm asking it, because why WHO is still today also made a statement that they are not going to include remdesivir into their purchase for poor countries. This says that for their purchase to poor countries, they will only support steroids. And they says we are willing to support monoclonal antibodies, but not remdesivir. That's a statement which came today.
Yes.
So on the contrary, the US says that they have cleared remdesivir for a personal use. But that's a good news. I mean, that's an important news that your country is not using remdesivir and Favipiravir. So I will now, what I do is I'll ask somebody to work on it to find out in which countries remdesivir is not used.
Yes.
And that will give us an indirect data, what is the mortality. In my cases, which I follow as an outpatient, I give them early steroid and early blood thinner. And normally remdesivir indication is when hypoxia develops. That is the indication by the company that if there is clinical hypoxia, you give remdesivir. So my emphasis is why allow them to go to that stage, treat them early, and if they don't develop anoxia, remdesivir is not needed. And Favipiravir is a weak RDRP inhibitor. It's a very weak RDRP inhibitor, and I don't know how the efficacy of it is a Japanese drug, unless we ask some Japanese person to talk about it with that. So anything else about Singapore? Which testing they are doing? Which testing they are doing in RT-PCR?
I think we are doing the RT-PCR. We're doing the spike protein testing. So spike protein, and we have our own. I think they've moved on to our own locally produced kits. So we have a couple of companies that have come up with kits, including our top research agency called A-Star, and they've come up with kits. So we're using those, and we're ramping up to about 28,000 a day. And interestingly enough, we are swabbing our migrant worker population, 300,000 of them every 2 weeks, regardless whether they're well or they're sick. And everyone in Singapore with a respiratory tract symptom will be swabbed. So that's
what I'm going to come back to the last part of our discussion, and that's post-COVID. That means after 9 days of COVID, people are suffering for 3 months. And they are having many types of presentations. Some have a presentation because of lung fibrosis. Others have because of continuing residual inflammation and fatigue, which is lasting. Third one is thermoregulatory dysfunction leading to fever, which is with normal C-reactive protein. What are the percentage of cases having persistent symptoms after 9 days when the virus is negative in Singapore, and how are you managing them?
Okay, I personally am not managing. I mean, my patients who have it are all very well, so I'm not managing those who are very ill and in the ICUs and what. But from what anecdotal experience I hear from my colleagues, it is seen as in most post-viral illnesses. Some patients have a lot of post-viral fatigue and so on, and others are actually quite well. The numbers who have a lot of post-viral symptoms are not that many, maybe about a quarter or a third of the patients. So this is a general anecdotal feedback that I've gotten from my infectious disease colleagues.
Anything specifically about fatigue? Are they trying something?
Well, a lot of my colleagues think that these fatigue symptoms are honestly, if you had a major infection, a major illness, I mean, I always tell my patients, even dengue, for example, I tell them, please allow your body up to 3 to 6 months to come back to normality. So I recall even myself when I had typhoid fever a long time ago in my 20s. It took me like 6 months to be fully tip top. So I think fatigue is really a real symptom, and we just have to ask everyone to take it easy, because the pace of life in Singapore, being such an urbanized city, and the work pressure and all that is very high. So patients tend to don't look after themselves well, if you know what I mean. The moment they come back from hospital or whatever, they're just dying to go back to work. And I think they hit the ground running too fast. So that's the problem we see in Singapore. We have
So
to tell
apart from
them
that,
to slow down.
before I just close,
Yes.
I'll ask one person to come and speak. But before that, what are the common health problems in Singapore? Apart from COVID, what are the normal incidents of rheumatic heart disease, ischemic heart disease, other diseases, dengue?
Dengue was pretty bad this year. So you saw that we had 28 deaths from COVID, but we also had 28 deaths from dengue, equal number of deaths. So our dengue was pretty bad this year because everybody stayed home and all the mosquitoes bit them because they all work from home. And because all our migrant workers were in the dorms and nobody was there to do all the maintenance. So a lot of pool water, fallen leaves and so on. And we ended up with a big outbreak of dengue. So that's a bad problem. Otherwise, as with most urbanized cities, we're looking at chronic diseases. So chronic diseases, the usual: diabetes 10%, obesity 10%, hypertension 20%, etc., etc. So, and leading on to strokes, heart attacks. So yes, the typical pattern of a urbanized environment.
So let's take few people if they want to ask any question. First of all, Saurabh, you want to ask anything? Saurabh, are you there? He might have gone to rest. Saurabh?
Yeah, hi.
Or you want to ask any question?
So I think that today's the news is the vaccine which Pfizer has come out, and I just want to ask the question is like what is a reality? Like it says 90% is more effective and the transfer of it. So what is when
I don't think so, Saurabh. I don't think so, Saurabh. You should be asking a medical question. You should only ask, should I buy the shares today or not?
So that I've already asked. Yeah. So what about the So my question was coming to that level that when it will come to the real market, and how will that impact the economy?
Sorry, can you repeat that again?
I said, how will that the news which has come today? What is the reality? When will it come to the actual market, and when will it go to the retail public?
I think it's going to take some time to reach us.
I'll read out something. I'll give you the answer. So bio and tech. Now I'll tell you the answer there. That they launched the phase 2 and 3 trial on July 27 in Argentina, Brazil, and Germany, and then on September 12 they have 43 participants. Now I'll tell you the economics. Pfizer and BioNTech vaccine, like almost in the summer, the companies began inking deals to deliver large orders to countries around the world. The Trump administration awarded 1.9 billion contract in July for 100 million doses to be delivered by December. That's the first order they have got, with an option to acquire another 500 million doses. That means something like $10 billion. They have already got a contract. Japan has already made a deal for 120 million doses. The European Union arranged to purchase 200 million doses.
Wow.
If the vaccine is authorized, which they have applied now, which they are applying now for emergency use authorization, Pfizer and BioNTech expect to manufacture over 1.3 billion doses of their vaccine worldwide by the end of 2021. That answers you, Saurabh?
Yeah.
So they already have 100, 600, 700, Well, I mean, they have a order of 1.3 billion doses. Now multiply it with the cost, you will get the market. Even if the vaccine in the European market is say $10 or $20, you can imagine it. It is going to be 30 to 50 billion dollars market of Pfizer and BioNTech. It can become zero if it was not effective. But if they say 90% effective, because all other vaccines are 50% effective, and if it turns out to be a 90% effective, I think this will be a game changer for them. Now, there are certain reasons. The reasons are till today, messenger RNA vaccine has never been tried in any illness. This is the first, for the first time in the world, they are trying because this doesn't contain the virus. It contains a something like a replica of a virus, which is being used, a messenger RNA, which is recombinant based messenger RNA. So this is, if it actually produces antibodies as they claim, this is going to be a game changer. So therefore, there will be internationally, talk to all your people in US, and you will find them. They all will be buying shares today.
Just to tell you, US stock market is already, I think, 5% up. So and Europe was 7% up, and I believe India will be like another 4% up. So the news is already there.
Incredible. So let's pick up Nidesh. What do you want to say, Nidesh? Nidesh,
sir,
are
good
you
evening,
there?
sir. You already yes, I am there, sir.
Yes, go ahead.
Sir, you already covered my question, sir. The use of steroid on a day and on which day. My second question to Dr. Chong is that, sir, the mask playing a vital role in respiratory disease. As a countries like Singapore, people wear masks regularly. That is the reason they fight with corona very well compared to other countries.
So
Yes,
just Dr.
I think
Chong,
so.
just to confirm about the which types of a mask people are using in Singapore.
Okay, so of course, the healthcare workers and so are using surgical masks, and I think quite a large number of the population use surgical masks, and everybody was distributed washable cloth masks, as well as a higher grade of mask, somewhere between surgical and just a cloth mask, by the government. So there's actually a lot of options for Singaporeans to wear various types of masks. But we anecdotally, we look around, a lot of people are wearing surgical masks, which they have bought themselves. So being fitted is another thing, whether it fits well and so on. But in public places, everybody must wear masks. Otherwise, they may be fined or they may be caught out or whatever. So there's quite a lot of enforcement. We have these people going around called safety ambassadors, and they are in crowded places, they're in markets, they're in malls, they're in many places, and they will approach people who are not safety distancing, they will approach people who are not wearing their masks, or they're not wearing their mask properly, and so on. So there's a big group of what we call safety ambassadors, and part of these were because a lot of people lost their jobs, and so the government stepped in and recruited them as safety ambassadors. So they are all over the place, doing some kind of moral suasion and gentle enforcement.
So thank you, Dr. Chong, for being here with us, and he has given us a wonderful information all about what's happening in Singapore. Translate that into what's happening in South Korea, Taiwan, China, and Hong Kong. You will find the same answers. The good news is that it's possible to reduce the mortality. It's possible to bring it to 5 per million. In India, the mortality is slightly on the higher side compared to Singapore, and the reason being huge population and a non-uniform infrastructure for treatment. So the message which has given is that if you are conscious, if you are aware of the illness, and if you have good facility to treat, you can bring down to the mortality to the level of dengue. So I'm going to close with a message, and the message is the mortality of COVID-19 can be brought down to the level of mortality of dengue, and that has been shown by Singapore. That's my headlines today, that dengue and COVID-19 has the same degree of mortality in the best of the centers in Singapore. That's all for today. Let me say namaste, Corona namaste to Dr. Chong. And to all my viewers, we'll be back tomorrow, 7 p.m. with another show. Keep watching Med Talks with Dr. K.K. Agarwal. Namaskar, namaste. Stay tuned.